Thank you, Dr. Unnikrishnan, for calling me over here, and it's a very important topic early in the morning. And I think I'm going to take you through a very nice series of some slides which are going to tell us about what exactly is bariatric surgery. You saw a lot of words, jingoism, and a lot of some play were happening, good, evil, and whatnot. We will try to tell you what actually is the literature till 2018, and there is no conflict of interest at all. What is the scope of adolescent obesity, which my opponent did not actually talk about? How obesity is different between adolescents and in adults has to be told to the august audience always. How a treatment is different from medical versus surgical. What are the mental abilities and capabilities of an adolescent when you talk about putting this particular patient into surgery? And one of our chairpersons is a pediatric obesity specialist over here. It needs a good mentor and a mutual understanding. I was sure that the surgeon is going to show mutual fund risk, but apparently he forgot to show the risks of the surgery. We need to get clearly difference between a pediatric metabolic syndrome versus what is obesity in an adolescent. What are the outcomes of long-term data? He showed you all the references till 2017, and I'm going to show you references of 2018 and 19, and how this update is going to happen today, absolutely, by the end of this debate and talk. What are the actual age of adolescents? In many of these studies, the adolescent age group was taken till the age of 21, and I would like my chairpersons and the audience to know this. So not all the data that has been shown to you was actually from an adolescent population. Growth, which is so very important. He just showed that jingoism about Thakur and that somebody not having a limb. But let me tell you about the growth. There are fractures seen post-bariatric surgery in adolescent if there is no proper choosing of the patient. Adherence is so very important, and why adherence is important, I'll show you in some detailed slides. Ladies and gentlemen, the prerequisite for surgery of any adolescent or adult is same as post-surgery, and that is lifestyle modification, right? And once lifestyle modification is not done even pre-surgery for adolescent, the guideline is so clear. If you cannot maintain, or if any patient or the family cannot do prerequisites of bariatric surgery and lifestyle modification before surgery, he should not be taken. So at the end of the day, अपन काय म्हणतात कि शुरू में जो आप घर में कर सकते हो वही आपको बाद में भी करना है. So if somebody is not able to do that, we cannot really put this particular patient at risk for this surgery. And I will show you data beyond what again he said, systematic reviews, consensus, and controversies. So I think here we start with the scope of the problem. The obesity issues have not just doubled, it have tripled in the last 25 years. And that's the cycle. Just look at the child in the blue, healthy child. Television, video games, trips, attending conference with parents, eating, not playing at all study and no action. I'm not sure whether you can see that. It's all study and no action. That's the time we need to talk about obesity to parents in schools and there. And once that is taken care, this mildly obese child and the whole cycle goes completely off. Now, my opponent showed you one slide that yes ke baad mein but is important, but if you just put yes ke baad mein and, that creates complete language difference that absolutely helps us to treat it very well. Yes, there are problems, and we all as mentors, we all as doctors need to tell the patient and the family that, and if you continue to do the lifestyle modification accordingly, they can absolutely do not grow into obesity. And believe me, we've been doing it so strongly and so hardly for all the schools, and it has given very good results, including in our own Indian population, our own Maharashtrian population, and people from Pune, Mumbai, and rest other places of Maharashtra, which I may not be able to take the time. Now, opponents usually show that complications of childhood obesity, but nobody shows you the complications of surgery of bariatric in adolescents. I am going to show you those things. Yes, these are there. How much weight loss it takes to get down this complication of diabetes? 5 to 10 kg if the patient has got pre-diabetes, and a mere 10 to 15 kg weight loss to cut the risk of put the patient in diabetes remission. It's so simple over there. And we've been doing this 15 kg weight loss for so many adolescents just with a proper follow-up, which would be needed even for pre or post-surgery without even putting the patient under the surgical knife. And when I use the word patient over here, I absolutely mean it is an adolescent. So why do we even need to think about surgery for obesity in adolescents? Because of this word and, which he showed you as but. This, because intensively acceptance of lifestyle modification and advice is not there. The way we all have fear of insulin initiation, similarly, somewhere physicians and all of us have a fear that maybe if I tell lifestyle modification more, that the patient may be lost. It's not like that. This is what we need to tell. वो अपना बच्चा है, भारत का भविष्य है, and we need to reiterate that repeatedly, that is required. Otherwise क्या होगा, वो सर्जरी कर लेगा, lifestyle modification नहीं करेगा, weight regain करके वापस आएगा वो. We don't want that, right? And you saw how he said about 80% stomach is cut. Boss, we do not know the long-term data of these people. इन लोगों का अभी bone mass accrue हुआ नहीं है. We do not know what will happen to their puberty. We don't know what will happen to their mentation. Adults में there are studies about neurocognitive and plasticity when the weight loss occurs. In pediatric adolescents, we do not have. We need to really carefully select these patients completely. Malabsorptive is out of question, but restrictive, he told you how it was 80% stomach is removed. But that needs to be seen in a very different way. Outcomes are completely different. And one more thing, because the population is different, we cannot extrapolate everything from adult to pediatric. It's a different population we are taking all together, and this is a very strong point that we cannot extrapolate all the data. And for remission, whatever he is told with his chest out, it is only about that 15 kg weight loss, which we can otherwise also do. And you require special surgeons, pediatric surgeons, pediatric team to get that. They are not just small adults, they understand everything. And they want to be treated in a way that they should otherwise. And there are a lot of ongoing issues with most of the surgical procedures, including endoscopic. I think there are newer terms in surgery, which I would tell you that are just laparoscopic banding and laparoscopic surgery, which can be done even within few minutes and patient can be sent home. And this is where we need to put our patients. I would advise, please refer to pediatric colleagues about pediatric metabolic syndrome, or start putting down patients into these particular chart. Do they really need weight loss, or how much weight loss, and how we can talk to the patient in this particular risk. That's a very important slide talking about risk factor in a pediatric age group where cardiovascular risk factors are to be taken into account and understand it in a better way for a better outcome. The first contraindication, the mutual market risks, physical immaturity itself. An adolescent age group, less than 18 to 70 years, are not yet physically mature unless otherwise the patient is dying of a complication because of obesity. Those are an exceptional case. Bariatric surgery is not a norm for all the adolescents, ladies and gentlemen. The second, which he did not show any slide, is the medically treatable cause of obesity, which is again a simple obesity, which is again a home-induced, which is again a lifestyle-induced obesity, and can be addressed very nicely and very efficiently. Inability to participate in follow-up. So if the patient is an outstation, patient is an out country, or patient is staying far off, has got understanding where he would not be able to follow up, we cannot really operate and just throw them in the dark in the jungle on their own. Cognitive inability to participate in decision, which is so very important. Active psychiatric behavioral issues, substance abuse, which is so very common even in Mumbai at the moment. I mean, MDA and LSD, this is there. Current or planned pregnancy, of course, in India we do not have these kind of issues presently, but this is not going to really tell us that it would lead to surgery. It would, of course, and obviously not. He did show you some old slides, but let us talk about which are those particular trials, some by FDA, the DuPont trial, the Fab5 trial, and others. Yes, it is a multidisciplinary, but not for everybody. And I think with that, what we have learned is that it's the only morbidly obese population that needs to be addressed, maybe for surgery, if after full 1 year of lifestyle modification has failed, then only. And that 1 year of lifestyle modification has to be done by expert, especially 3. One physician interested or an endocrinologist, preferably a pediatric person involved, and a psychiatrist or his team need to be involved to even say that this patient has failed an LSM, which is so very difficult. So what do we do then? Awareness of obesity is really there amongst our people, and that is why we are getting back through the schools of how to tackle this particular problem. adherence is very important, ladies and gentlemen. The way we have it, we've been doing it in the past 5 years, it's not just like that. You try to touch an adolescent with a surgery, their own guidelines and 2018 data from Ingle and Obstler study, Lancet Endocrinology and Diabetes Journal, which just came 6 months back, it clearly says that the adherence to therapy before and post-surgery is more important than the eligibility of surgery itself. So let's understand the importance of this lifestyle modification, which is just taken with a pinch of salt, sometimes with us by the fear of that inertia. We need to come out of that. We really cannot put everybody unless adherence is an issue, and they need nutritionists and psychologists post-operatively, if at all they are operated, if at all they fail, and encourage their compliance in this group of patients. Growth failure is so very important. You all saw the first contraindication, which said physical immaturity. It can lead to, now, it can lead to malabsorption, it can lead to vitamin D deficiency, even if treated with high doses. Now, let's get this statement very clearly. Growth failure for a skeleton where bone accrual has not yet happened can lead to osteopenia, can lead to rickets, can lead to even fractures. We do not have a growth velocity data. Pediatricians in the hall would understand what I'm talking about. So till we have a data on growth velocity, surgery cannot be thrown upon to all adolescents at all. And there are, when we talk about supplements, they do not adhere, which is so very important in restrictive procedures. Less than 20% of the patients actually take recommended supplements. These are children, they need it so badly, and it's more of a nutritional deficiency, but people do not take. So adherence, that's why checking is very important and emphasizes the role of awareness as well as both. Age of adolescence, I was talking to you about in the agenda slide. This age of adolescence is really important to understand. There are many medical causes. We cannot put just en masse surgery to anybody, any adolescent over there. The risk of surgery need to be thoroughly considered and discussed with the patients and their families when considering, if at all, which was very much conferred upon by the AMOS study, the FAB study, and the Ingle and the Obstler's paper, which came recently few months back. Now, again, the risk of complications, which is usually not shown by people, which are largely unknown. One, that's how we started talking. The recurrence of weight gain, the recurrence of diabetes, the recurrence of heart disease and the risk factors. Reoperation appears to be a slightly higher than seen in the adult cohort. I would read this line again and concentrate on this particular third point. Resurgery appears to be slightly higher than in the adult cohort if the patient is not selected. That is another reason, and my third point, very importantly and strongly I put forth that why it should not be extrapolated completely from an adult data. It is imperative that surgery should only be provided by a multidisciplinary approach if at all there is a failure after a long-term trial of lifestyle modification. There are inconsistent guidelines, including the surgical guidelines themselves, ladies and gentlemen. The NICE guideline, UK, which is supposed to be very authentic and very strong, they say that this surgery is to be done only under exceptional circumstances. He showed you about IDF 2010. I'm talking about NICE 2014 and beyond, what has happened in the last 5 years. The IPEC data, which is again an endoscopic surgical issue, they say that adolescent, if at all do need to operate, they have to attain the adult maturity or the adult stature, otherwise it can cause long-term problems which we do not know. So again, we're talking about a special population. We're talking about a population where we do not know about whether it is life-saving or not. So it's a very small thing. Obesity खूप far hai, but that surgical thing is very small patient who may require at all. Diabetes कम करने के लिए 15 kilo, I mean, which is so very easy in most of the patients. And he showed you in one slide that PCOS is a lesser problem, and I think I would completely disagree on this next day morning of International Women's Day. PCOS is a huge problem and it needs to be addressed, and believe me, LSM again does that very nicely. So all guidelines are similar only in one thing, ladies and gentlemen. And what is that one thing? They say that it should be done by a multidisciplinary team, which we all agree, which we all know, even sitting in any corner of any village in India, we know that, yes. So inconsistency amongst guideline itself because of lack of data is completely there. The question are, is there really a long-term benefit in doing this surgery instead of doing it in early adulthood? Can we not postpone it if at all, if it is life-saving for an adult? What if any surgical procedure is best? We do not know. This question needs to be answered even in 2019, 9th March today, as on 9:55 a.m. What should we do with severely morbidly obese children who have limited decisional capacity or unstable family units? The family together has to be really taken into important, and I think I would like to stop over here, and I would take it in rebuttal. Thank you, madam, and thank you, sir. Thank you, ladies and gentlemen.